We have today Dr. Keyur Patel. We know him quite well. He is a very fond of MPI. He had earlier come to India and delivered talk. He is an Anderson Cancer, Houston, Texas, professor, Department of Hematopathology, Division of Pathology and Laboratory Medicine, medical director, Molecular Diagnostic Laboratory. His areas of interest is molecular diagnosis, NGS, hematpath, liquid biopsy, precision oncology, etc. His educational achievement is board certified in anatomic pathology, clean pathology, hematopathology, molecular genetic technologies. So, and of course, he is recipient of Distinguished Award, Team Science Award for Leukemia, MD Anderson Cancer. We welcome you, Dr. Keyur. Thank you.
Good morning, everyone. I want to thank the Molecular Pathology Association of India for allowing me to be a part of this momentous 10th annual conference. Many congratulations to the entire association and especially to the organizing committee. I want to thank Dr. Mishra and Dr. Rahman for allowing me to join virtually. I will be presenting today molecular biomarker topics in the recent classifications of hematolymphoid neoplasms. As a brief overview, we will be discussing briefly the history of classification of hematolymphoid neoplasms, followed by a focus on the key updates in recent classifications, particularly in the myeloid neoplasm classification, and we'll conclude by the practical implications of updated classifications. And no history or presentation on a classification of hematolymphoid neoplasms is complete without understanding some of the context under which these classifications have come up. Although there were many other classifications, attempts, and schema in work or in progress, Dr. Rappaport was one of the first pathologists who came up with a comprehensive classification, which was published in 1966. And soon after it was published, a book review published in 1967 identified that the publication was submitted in 1959, and by the time it came out in 1966, it was already considered lagging behind then current applications and then current clinical practices. So this again highlights that no matter how current these classifications are, the science and the field and practice of medicine continues to advance, and therefore some of these classification systems may soon become out of date, and thereby the need for continuing to update this. At the same time, the reviewer was kind enough to identify that all of the limitations in terms of the timing of the publication was still of interest and value, and it deserve a more rapid publication. So what followed after that was a series of publications and classification attempts that initially integrated morphology and then integrated morphology with phenotype, subsequently clinical behavior, disease entities, and recently genomics. And you can see examples of this evolution over time. And also what you see here is the evolution from having one single expert to a limited number of experts to many experts who are now contributing to these classifications. And in along these lines, we are going to be discussing today the 2022 classifications that are published concurrently by WHO, as well as the International ICC committee. To show the approaches for hematopoietic neoplasm classifications, initial classifications focused on morphology, then it also involved understanding the immunophenotype as well as other protein characteristics, which are moving more towards understanding the genomic characteristics. So this highlights and parallels the evolution of this effort. And I'm pleased and fortunate to be trained under Dr. Rete, who's trained under Rappaport. So I consider myself very fortunate in that regard and be able to contribute to some of this effort. So what has happened in recent years is we have moved away from solely doing morphology-based assessment to now integrating as many possible diagnostic modalities available to us. example of some of the lymphoma workup that you see here. We use immunohistochemistry to identify the immunophenotype of the neoplastic cells. We also use in situ hybridization to possibly detect any other pathogens that may be present. We use fish analysis to identify any copy number alterations as well as any small alterations that may be present. And as needed, we also perform molecular studies to determine clonality. Has now been happening more and more is also performing genomic analysis so that the different tumor types can be substratified into different prognostic classification. So overall, in a modern workup of a hematopoietic neoplasm does include a comprehensive assessment and a comprehensive approach using multimodality testing. And also quickly branching away from being limited to only the conventional tissue types, such as the lymphoma tissue, lymph nodes, and blood. And we're also looking at cell-free DNA in more and more tumor types. So this again provides an exciting opportunity to move the future of clinical practice, where this can lead to some wonderful advances in the personalized therapy. If we look at the myeloid side, the myeloid classifications or myeloid neoplasms oftentimes are seen in terms of from lower grade to a higher grade neoplasm, as shown in the left. Unfortunately, the progression is not always linear, as shown in the graph on the right-hand side, that it's a combination of process imagery, any proliferative phenotype or dysplastic phenotype, which leads to this constant shift or constant two-dimensional pool in morphology and immunophenotype, which is as shown here with a significant amount of overlap. And oftentimes these overlaps are very challenging to decipher beyond just using the morphology and some of the clinical laboratory data that is available to us. Fortunately, through recent advances in genomics and genomic platforms, we now have identified a variety of the genomic alterations that can alter a variety of different intracellular processes. So thereby lead to impairment of either differentiation of a general cell lineage or differentiation of a very specific lineage, that followed by a secondary activation of some of the proliferative pathway can lead to the hematopoietic neoplasms. Beyond understanding this at the cellular level, we have now also identified variety of different pathways that are utilized by diseases such as acute myeloid leukemia, example as shown here. The pathways altered in the de novo AML versus secondary AML, and in what order these are acquired or these mutations are shown acquisition, as shown here. Combining all of this information really allows us a very powerful insight into the pathogenesis of these tumors as well as their clinical behavior. So combining all of this information really and through the recent explosion of amount of information that's available, it really forced the large number of international experts to take a look at the WHO classification, the revised fourth edition that was published in 2017, not so long ago in the chronological time, and to say, is there an opportunity for us to further refine how we look at these tumors and from the lens of genomic alterations, and can we make them more genomically informed? So what is better than one classification? I guess two is better than one classification, and that's what we are seeing here. On the left-hand side, we have examples of the fifth edition of the WHO classification. On top is the myeloid, and at the bottom is the lymphoid version. Right-hand side, we are seeing a classification system that's proposed by the Clinical Advisory Committee of the WHO group, which now goes by the name of International Consensus Classification 2022. And then parallel example of myeloid and lymphoid on top and bottom. So for future generations who are putting together these slides and images to show the history of neoplasms, how they were able to find the images of all these experts. Joke aside, I think this really highlights that a large number of international community members, including possibly some in the audience here, are involved in these types of international consortium efforts so that we can now have a more genomically informed classifications of hematolymphoid neoplasms. So with that in mind and the large scope of two large classifications involving a large number of different clinical entities, and given the limited amount of time that's available to us today, I would like to focus my exploration to key concepts rather than cataloging every single change. There are some wonderful papers out there. Many of you may have already done this cataloging as part of your clinical practice. So I would like to focus on some key themes today. I won't be covering the lymphoid neoplasms. I won't be going too much into the morphologic criteria and the laboratory findings. And those are all topics of larger discussions on their own. And I won't be going into within the molecular biomarkers themselves. I will be going into issues such as what if the same biomarker at a different VAF is detected, or what if the same biomarker is detected in a different situation. So these are all again definitely great questions to ask and to address using scientific data. But again, beyond the scope of what we are trying to accomplish, which is reviewing some key changes and how we can move forward from the diagnostic standpoint. Overall, what we see is there are some common themes in the continued evolution of these classifications. On the left-hand side, you see the observations, and on the right-hand side, the explanation. So we've been moving from observations to explanations in this classification system. So we saw cytopenia, we identified clonal abnormalities. Some of those are now added as part of the new classification. We used to see sideroblasts, ring sideroblasts that is, and now we know they're coming from splicing factors. So they've been added to the classification. We used to note a very poor outcome in a certain group of clinical conditions, and we have identified the culprits, for example, P53. So they've been added to the classification, so and so forth, and including some clinical presentations that are very unique. And now, with the understanding of underlying genomic abnormalities, some of those have also been added to the classification, such as the Vexas syndrome. So with that in mind, let's look at some of these examples of these newly added entities. So one of the entities that's been added recently is the one that's called myeloid precursor neoplasms. I will be following this theme where I will be showing the comparison between the fourth edition, the fifth edition of WHO, as well as international consensus classification, and using some of these wonderful tables that are available through Zhang et al. Publications. I would urge the audience who's interested in reviewing this further, look at the article and also identify the supplemental tables that provide very nice comparison of these findings. The important feature of these lesions is that we have been noting since we started doing this broader genomic profiling, such as the next generation sequencing, that now we were seeing combinations of sometimes having a clonal abnormality in some of the genes which are important, such as the ones which are shown here in this table. However, these abnormalities may not always have been associated with cytopenia. So the question was, what do we do with these alterations? And so some terminologies have been floating in the literature for quite some time now. Through these classifications, they have been now formally recognized and consolidated into these terminologies, such as clonal hematopoiesis of indeterminate potential, or clonal cytopenia of uncertain and undetermined significance. And these are often differentiated between by having a cytopenia or no cytopenia. They both would have the clonal abnormalities underlying, and so forth. Sometimes we have cytopenia, but no abnormalities. And so it's important to understand that some of these terminologies are also a function of the type of genomic panels which are used. So if the panel tested does not use some of the commonly mutated driver genes, then coming up with a terminology such as ICUS may be limited because we haven't looked enough. So we have to keep in mind that these are all in the context of appropriately available or appropriately performed genomic profiling. So these are some of the key caveats from the myeloid precursor neoplasms. Again, they are recognizing that the clonal abnormalities with or without cytopenias can occur in the absence of morphologic findings. And there are also some additional conditions that's been added, such as, for example, for the ICC, they've added a terminology for clonal monocytosis of undetermined significance, as well as the Vexus syndrome, when these conditions with autoimmune manifestation and underlying UBA1 mutations are seen, and there are no other MDS defining genomic abnormalities. So as you can note here that essentially none of these entities have the name of the biomarker in the definition or in the terminology. However, to come to this interpretation, it's very important that appropriate types of biomarkers are tested. So this is one of the examples. In case of other examples such as myeloid lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions, this is building upon the previous entities that were said with some changes in the terminology. Here, as you can compare, keeping primarily a lot of the previous fusions that were detected, but also adding, and you can appreciate the commonalities and differences between the two recent classifications shown to the right, and number of different kinase fusions being added. So again, you can see that the large number of genomic abnormalities are now actually entering the diagnostic terminology here. One of the major advances or important changes that's been incorporated now is the role of P53. We have always known that P53 impart a poor prognosis in many of these entities, but the role now has been formally integrated into diagnostic terminology. For some of these terminologies, the WHO classification uses the term such as biallelic P53 inactivation. ICC uses the term multi-hit P53 mutation. And as you can see here, there are different ways of incorporating this. Looking at this panel on the left-hand side, we know that a healthy cell requires both the wild-type copies of P53 as the tumor suppressor gene, a single hit by way of deleting the short arm or 17p locus containing P53, or having one of the alleles mutated does affect one allele of P53. However, there is a normal or healthy allele present, and these cases have shown to be behave differently, at least for MDS, when it comes to MDS. However, in cases where there are multiple hits to P53, where one allele can be mutated, the other can be deleted, and so on and so forth. So by having these different combinations, we can now identify cases with P53 alterations affected through these different mechanisms. And that's the level of genomic details that's now been incorporated in these classifications. So if you look at the example of the P53 activation in WHO classification for MDS, it does require biallelic P53 mutation, and we can define that by having loss of any type or alteration of any type, such as a sequence variant, segmental deletion, or copy neutral LOH, which essentially leads to any wild-type P53 protein. And this could happen by having two distinct P53 mutation. And because we are not able to sequence long reads currently on a majority of the platforms, we just are allowed to assume that more than two distinct P53 mutations can be interpreted as biallelic. Similarly, one mutation and one copy number loss, or LOH, can also be considered as biallelic mutation. On the other side, the ICC classification actually introduces the VAF requirement. So two distinct P53 mutation with more than 10% VAF, or if there is a single mutation then the requirements are slightly different. There needs to be a deletion or documented deletion. If there is no cytogenomic information available, a VAF of more than 50%, again, showing an indication that lack of a Y type allele can also be utilized. So these are the examples how this genomic information is now actually being incorporated in these classifications. When you go further in AML classifications, there has been a number of different entities which are added. And again, I won't be able to go through a lot of these are all cataloged very well in publications such as this. What's important to note here is that both classifications are beginning to diverge a little bit in how they approach. So, for example, ICC classification seems to be introducing this additional variation in common translocations like RARA, KMT2A, MECOM, where they are differentiating between the common translocation as well as other in order to allow differential recognition of the common versus rare translocations. Number of new translocations have been added, so anything that shows not included in the fourth edition and has populated entries on the right-hand side essentially shows the large number of fusions, very specific fusions are added. Some of them will require more than 20% blast, such as BCR-ABL1, but a large number can be also utilized with less than 10%. Some of these are seen more in infant and children. So there is a recognition for different clinical-pathologic features of many of these alterations that are noted here. Again, there is a large number of these entities, and each entity has its own unique clinical-pathologic feature, thereby allowing us to giving us opportunities to understand this at a much more granular level. One of the other significant change that's been introduced is in this category of myelodysplasia related alterations. While in the previous examples, some of the morphologic lineages as well as cytogenomic abnormalities were clearly identified. Now, in the fifth WHO classification as well as the ICC classification, a clearly defined group of genetic alterations, such as these 8 genes, have been introduced. The ICC classification includes the same 8 plus RUNX1, and also there's been changes in the terminology of how these entities are called, with exclusion of some of the previous terminology such as therapy related in favor of a more appropriate terminology in WHO classification versus the ICC classification. So this is again showing and highlighting that in any given type of an AML workup in an appropriate clinical pathologic background, understanding the and interrogation of these different gene mutations would be very important for a complete workup. This is a table highlighting the recommendations. For the WHO classification, 2 papers were published as support of the primary classification and providing some more helpful insights and some recommendations for what types of genes should be included in the workup and what structural variants should be included. Again, this just highlights some recommendation and just for different types of hematologic conditions, starting from MDS, MPN, just showing the number of different alterations versus MPN and so on and so forth. So this again has important implication for diagnostic laboratories which are trying to provide a diagnostic support for the initial diagnostic workup for these patients. Again, in the same publication, we also try to provide some common comparisons of common mechanisms for cytogenomic analysis on the left-hand side, and also some targeted and exome sequencing to all the way to whole genome sequencing, and types of alterations which are supported by each of these techniques in order to allow the selection of the appropriate technique, and also for some possible uses of these types of methodologies. So while the classifications do point out the need for a lot of these different genomic alterations, This supporting literature also provides some indications for what type of methods could be useful for the same. In terms of the practical application of these type of recommendations, we now recognize and we've seen the need for this type of integrated approach. This is showing a 81 gene panel that we use at MD Anderson Cancer Center. And you can see how different biomarkers are carefully selected here that would cover a variety of these different conditions that affect the bone marrow and can support the WHO classification. Sometimes having the biomarker alone is not sufficient, and we are now needing more and more this biomarker information on a rapid basis. So this is an example of a proprietary platform that we have developed on which we provide information out of our 81 genes. We provide information for several of these genes shown on the right in a rapid 48 to 72 hour turnaround time. Given the emergence of P53 more for diagnostic as well as therapeutic applications, we have added P53 to this initial 10 gene reporting. Now we're reporting 11 of these genes in this rapid turnaround. So these are also important considerations while we develop diagnostic tools to support these applications. What if, for a variety of reasons, these tools are not available? There could be a simple solution. Some of the colleagues in our group, Dr. Joe Keyur, Dr. Sanam Dogari, they worked extensively on developing a P53-based immunohistochemistry. This study was again published in Blood to show a high degree of concordance between the P53 immunohistochemistry, which can serve as the screening tool or can support the P53 assessment status. It does require a little bit of an experience and also interpretation, getting acquainted with it, but this could provide a good surrogate marker or surrogate method when rapid P53 sequencing is not available. When you have all of this information available, another practical aspect is that how do you bring back all of this information in a meaningful manner so that you can come to the appropriate classification mapping back to one of these classification systems. This is showing an example of a decision tree provided by the 2022 AML-ELN guidelines, where through an algorithmic approach, one can go through and combine the clinical pathologic features along with available genomic information to derive the classification schema. Along with it, we also need these types of risk stratifications where we have now established the diagnosis, and that creates a challenge in the sense that we used to have a limited number of diagnoses to deal with. Now, if you make the list of unique clinical entities much bigger, it becomes very challenging to also accommodate the prognostic determination on those different clinical entities. Again, this is coming from the ELN 2022, where these different entities can be stratified based on the genomic alterations into favorable, intermediate, and adverse. So what these types of efforts are again highlighting is that getting the information is not alone is not sufficient. They also need to be translated back into appropriate reporting as well as the clinical decision-making information. So hopefully what I have shown you during this very rapid fire review of these two large systems that have really come up recently for classifications is that they are following these common themes, oftentimes using the origin of the variant, which relates to the germline predisposition syndrome, or lineage and phenotypes such as the MLNTK, eosinophilia entity. It can also take into account the allelic involvement, such as in P53 or CBP alpha, functional impact in terms of morphology or cytopenia, such as CHIP, CCUS, or MDS. It also looks at the types of alterations, ITDs, fusion, and so on and so forth. In some situations, there is also consideration for stronger or weaker pathogenicity and need for supporting blast or other features. And also sometimes it looks at the fusion partners. So what we are seeing overall here is there is a recognition that not all mutations, not all genes, and not all biomarkers are equal. And we are now looking comprehensively at different domains or different characteristics of these alterations. So in summary, between comparing the recent classifications to 2016, many entities have remained unchanged. And with regards to the two new classifications, there is a significant overlap between the two. There are also very important, some significant updates where additional categories have been added to both, such as the ones listed here. There are some in one but not the other. There are also some variations in the qualifying alterations between the two classification, and also there are some variations in the terminology. So while the recognition of genomic alterations are there in both, the way they are approaching them may vary slightly, and that's something to keep in mind. What it means for the diagnostic community is that we need to have comprehensive analysis platforms for diagnostic evaluation. That means that we need to transform technology into meaningful tools so that we can now use that information moving prospectively, because we know that retrospective studies can generate the knowledge. And so we can define all these different entities, but if we have to really move the needle in terms of improving outcomes in these conditions, we have to apply this prospectively in clinical applications so that the outcomes can be changed. And finally, in terms of the pathology reports, again, we may be seeing and we may be prepared for including the two classifications in one as needed. And also, when all genomic information is not available, possibly a two-step reporting strategy where the immunophenotype and morphology-based reporting occurs first, followed by when genomic information is available for a complete integrated information. So with that, we'll come to the question that's been on everybody's mind. So in this classification schema, what happened to the lymphosarcoma of the intestine, one of the most famous conditions that's been popularized by the movie Anand. And as you can see here, this public entity was first published in 1922 using two clinical cases. And so somebody in the world would do some homework. They probably don't look at the most updated classification when the movie came out. So we still have this terminology floating around, not in the scientific literature, but in the popular literature out there. So with that, I want to thank you all for your attention, and I'll take any questions that you may have. And thank you again for allowing me to join this conference. Thank you.